Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This week, we're stealing a little content from the Only in Staten podcast, one that I work on at my institution, Staten Island University Hospital. And I got to sit down with one of our burn specialists, the director of our burn unit, actually. And we're going to give you that interview in its entirety. And you can pop over to the Only in Staten podcast to check out all the things that we're doing over there. We've got some other great casts. Some of it we will bring over to Rebel, but there's more over there than what we're putting on Rebel. So go ahead and check that out too. All right, let's get to the interview. Today, I'm here with the most famous burn doctor in New York City, Dr. Michael Cooper. Mike, welcome to the podcast.
Thank you for having me.
Yeah, it's great to have you on. And I love bringing in consultants where there are things that we do in emergency medicine, but we don't do often. And so it's really nice to grab our consultants and go into these topics. And since you are a burn doctor, that's what we're going to be getting into. We're going to be getting into acute management of the burn patient, looking at some of the typical things that we think about in management from the emergency medicine side, from the resuscitation side, and where those things might go a little sideways if we're not careful. So are you game to get all of us up to speed on our immediate resuscitation in the burn patient?
Yeah, let's do it.
All right, so let's start with one of the big questions that we get all the time, which is the choice of and amount of fluid resuscitation that we should be giving these patients. I think for a long time, it was just give them a ton of fluid and figure it out later. I think, though, we've gotten a little bit more conservative. And I think it's important for us to think about what fluid we should be giving and then what we should be starting with as a bolus volume.
Yeah, today it's more common to see the patient over-resuscitated than under. I think that we all agree that for a large burn, and for us, any burn over about 15% total body surface area, we consider a large burn. And the reason is those types of burns have an activation of the systemic inflammatory response syndrome. And so areas that are not burned will also be edematous. You don't want to over-resuscitate the patient because you can put someone into pulmonary edema. And you can also, because of cutaneous edema, you can make the burn worse. Decreased blood supply can make the burn deeper. You don't want to under-resuscitate, obviously, because you can have end organ damage, such as kidney failure. You can have a mesenteric infarct. You can have acalculous cholecystitis. So it's really, as you said, it's a balance. And if someone has a hand burn or a smaller burn, 10%, then I use maintenance and a half. So the typical 70 kilogram gentleman, I may have him on LR at 150. I use LR or normal saline because it's isotonic. Once we get into the larger burns, 15, 20% or greater, then they're going to need more fluid. And I still like to use the Parkland formula. Now, if you read the literature, the Parkland formula gets a bad name. Some people said over-resuscitates. But I think it's a good way to, and an easy way for all of us to start. And it's 4 cc's per kilogram per percent burn, half over the first 8 hours, half over the next 16 hours. But what we do is we use it as a way to get started. And so if it's a large burn, we may start at LR, let's say 800 cc's an hour. But then we look at the response. So if someone has an adequate urine output, they're hemodynamically stable, then that's a good place. If they're dehydrated, hypotensive, not making urine, then we may give more fluid. So again, I still like the Parkland formula, but I use it to get me started. So I think that's a good place to start.
Let's clarify a couple of things there that I think are really important. The Parkland formula itself may not be the problem. What might be the problem is our overestimation of the burn size. And I see this all the time. I've done it myself where I look at a burn, I call my burn specialist, I'm like, I think it's this percent. And they come down and see the patient and goes, no, it's like half of what you're estimating. So it's important for us to do that good estimation at the beginning before we make that calculation. And then with the percent body surface area, if I'm not mistaken, Mike, we're mainly looking at either the second degree burns or third degree burns. If they have like a surrounding first degree, we're not including that in our total body surface area calculation. Is that right?
Yeah, that's a very important point. It's only the second and third degree burns that we consider when we are looking at the total body percentage burn, the total body surface area burn. Problem becomes that sometimes what we think is first degree may actually be second degree. Or sometimes what we thought was gonna blister and becomes second degree is not. But we can tell that many times by the response to our resuscitation. If you look at the Parkland formula and you start someone a certain amount of fluid, let's say 500 cc's an hour, and at 2 or 3 hours, they're not making urine, they're not hemodynamically stable, they're dehydrated, then perhaps you under calculated. So maybe instead of thinking it was a 20% burn because some of the areas were only red, maybe they're actually second degree. And so maybe it's a 30% burn, but you would get a sense of that by the response to resuscitation. The same thing is true the other way. If, let's say, one estimated by the rule of nines, and we'll go into that it was a 30% burn, but the patient is making 200 cc's an hour of fluid, well, you may have overestimated the percentage. So you would simply decrease your fluid. So you can get a sense of how you estimate the percent burn by the response to your resuscitation.
All right, before we move on to our next topic, let's hit that rule of nines. Give us a quick, dirty rule of nines that we can use for estimating the size of that burn.
Sure. It's a great, easy formula to use. Where in an adult, the head is 9% of the total body surface area. Each arm is 9%. Each leg is 18%. The anterior chest abdomen is 18%. The back is 18%, and the perineum is 1%. For infants, it's the same, except that the head in an infant is worth 18% total body surface area, whereas the legs are 13%. So kids have big heads and little legs. And as they get older, we take, as their legs grow, we take a percentage off the head, place it on the legs. So by the time they're 6 or 7, they're the same as an adult.
All right, so those are some good rules to kind of just get a basic estimate. But again, I think the key here is you're going to start with a bolus. You're going to reassess the patient. You're going to look at that urine output. You're going to look at that blood pressure. That's going to help to give you a sense of, have I under resuscitated or over resuscitated? And that can guide the rest of your fluid management. Let's go from there to airway assessment. Maybe we should have led off with airway assessment. A is always first, but I think we've always prioritized airway. We're learning in emergency medicine more and more, not that the airway isn't vitally important, but sometimes we should be prioritizing circulation and things like that before the airway. But one of the big questions in emergency medicine with burns is the indications for intubating a patient. There's a couple of papers recently that have come out saying, maybe you guys are over intubating. Maybe you're overestimating the risk of this patient losing an airway or getting edematous. So what are kind of the hard indications to say, I really should intubate this patient? And where do you think maybe we're going wrong a little bit?
One thing is the history. So if someone has a history of an enclosed space fire, an apartment, a house, a car, those are the house fires, or those are the indications that you may have an airway compromise. So if someone is outside barbecuing, they may have a face burn, but most likely they don't have an inhalation injury that requires mechanical ventilation. Because they're outside, it's just not enough concentration of noxious gases. But the history will lead us if there's a house fire, if there's a car, apartment, what have you, and if the patient says, yes, it was very smoky. So those two things are going to lead us to think that we may have airway compromise. And then a hard indication is the patient in respiratory distress? If the patient is having difficulty breathing, if the patient is not satting well, then I think it's very important to protect the airway. Don't wait until you perhaps have cord edema, vocal cord edema, when you may have very difficulty securing an airway. So to me, those are the hard indications. Someone comes in, they have a great story, a great history of being in an enclosed space of fire, being very smoky, and they have respiratory distress. I think those patients should be intubated right away. If you have the same patient, but they're not in respiratory distress, we still have to be very suspicious, but now we have time. We can put them on 100% oxygen. We can place them on a monitor, including pulse oximetry. If they're not in respiratory distress at the moment in the emergency room, one can wait and can observe that patient. But it is more aggressive, and this is a bit of a paradox, it is more aggressive to not intubate than to intubate. You can tell many times by the saturations, but also if they become very hoarse. And what I will do if I have a patient that I'm concerned with, I'll go by and say good morning. And the patient says good morning. 2 hours later, it's a very high-pitched good morning. That patient should be intubated. I've had to do 4 emergency tracheostomies on patients who were watched and then went into distress because of vocal cord edema. They were not able to be mechanically intubated by the emergency department or anesthesia, and we had to do emergency airways, and very difficult.
So clearly, if the patient is in respiratory distress in front of you, we're going to take that airway. That makes a lot of sense. If they've got upper airway noises on your examination, so whether that is that high-pitched voice, if they have stridor, obviously those are signs that there's a lot of edema in that upper airway, and those are patients that you want to take the airway sooner rather than later. We have definitely switched outside of burns and emergency medicine to looking at patients in respiratory distress and trying things like non-invasive ventilation and very successfully getting to points where we don't have to intubate the patient. That is not this group. That's not this group because these aren't just physiologically difficult intubations. These can be anatomically difficult. So if you have the patient in respiratory distress, if you hear those upper airway noises, you're going to want to go ahead and take that airway. And I think that's part of the reason, Mike, why we probably do over intubate a little bit, because we're more worried about losing that airway, having it to be very difficult to take. And we don't do trachs, means we have to do a crike, which we'd like to avoid. I think that's probably why we're probably over intubating slightly at the risk of making sure that we don't miss someone who in an hour or two is going to have a very anatomically challenging airway to intubate.
My final thought on it is that if there's any question, I agree with you. You should secure the airway.
Excellent. Let's get to another one of the uncommon procedures that we have to think about in burn patients, which is the escharotomy. I'm going to be honest with you, Mike. I've never done one. Never done an escharotomy. I've seen one in the past, and I don't think we can really take the time on the podcast to walk someone through how to do an escharotomy, but I do want to talk about the indications, how we can look at the patient and say, oh, I got to pull the trigger. I got to do this.
Yeah, escharotomies are usually performed in a patient with a circumferential third-degree burn, because with the resuscitation, the extremity doesn't expand, so there's pressure inside of the muscle compartment. The way that we're able to diagnose that is that if a patient comes in, they have a palpable or Dopplerable signal, let's say a radial artery signal, Dopplerable signal, or palpable pulse, and then they lose that signal with resuscitation, then that's an indication for an escharotomy. Now we have to be careful because remember, there's the escharotomy, which is simply cutting through the burned skin. That's different from the fasciotomy, which is opening the fascia. However, and not to confuse things, but if we lose our signals or lose our pulses, then we do an escharotomy. And we can do it right at the bedside with the cautery. However, if we do an escharotomy and we do not get return of our signals, or pulses, then we go on to do a fasciotomy.
One thing that clearly then is really important is, one, to document distal pulses in all of these patients, especially if they have a circumferential third-degree burn. And then you got to recheck those pulses frequently. So these patients are staying in the emergency department for longer periods of time. We need to make sure that we are frequently checking those pulses to make sure they are still there, because that's going to be the clue that I need to cut, I need to do something to open that escharotomy. And then I like the tip that you had. If the pulse disappears, you do the escharotomy. If the pulse is still gone after the escharotomy, we have to do a fasciotomy. And neither of those are procedures that I think many emergency physicians are going to be comfortable with. Hopefully you have a surgeon on call that you can get. I have Mike. It's perfect. I can call him at home. He'll come in and help me out with this, but hopefully you have that resource. If not, there are some great procedure manuals on how to do these. We'll link that for people to look at, but I think we just have to know clearly the indication and be monitoring those pulses so that we catch it before it gets too far gone and we're waiting too long to do that procedure.
That's correct.
All right, let's move to a little bit of an easier topic, Mike. Let's talk about prophylactic antibiotics. We've got a patient who comes in, let's say that they've got a 15% body surface area burn. It's mixed second and third degree. Is there a role for prophylactic IV antibiotics?
Usually we do not give prophylactic IV antibiotics. and there's been studies that if you over treat with intravenous antibiotics, you can um, promote or it can be progression to more virulent. You're really going to be very judicious in your use of antibiotics. Um, we tend to give antibiotics sometimes if we're discharging a patient. Many patients request antibiotics, and sometimes we have to advise them that is not needed. So if someone has a burn and perhaps they were in an industrial area, if they were in a dirty environment fixing a car, something like that, then I may give antibiotics when they come in. I may give antibiotics if they're being discharged. But if someone had a scald burn of 15%, they do not need prophylactic intravenous antibiotics.
Contaminated wounds, give the antibiotics. That makes a lot of sense. This is kind of very similar to trauma patients. If the trauma patient has a contaminated, dirty looking wound, we antibiotic them. I think that makes sense, but we shouldn't be routinely antibioticing these patients. All right, let's talk about that house fire again. That seems to be what we've centered on a little bit with the airway information. One of the other questions that comes up is when I have a patient coming from that kind of a setting, what's the role for hydroxycobalamin? Should I be using it empirically for patients? Should I be looking for certain triggers to give that drug with the concern for cyanide toxicity? What's the standard that you kind of fall back with?
Well, the FDNY has really been a leader in starting the cyano kits, even before the patients, come to the emergency department. But certainly in an enclosed space, very smoky house fire, and the patient has a very large injury, then 40% or greater. I think that's an indication. Also, sometimes we'll have patients who have to be coded in the field because of smoke inhalation. So we know that the carboxyhemoglobin is going to be 40, 50%. And along with that, they're going to have a cyanide exposure. So in those patients, I think starting the cyano kit, starting the carboxycobalamin right away is indicated.
So cardiac arrest, we're clearly going to give the hydroxycobalamin. Large burns, enclosed space, we're probably going to give the hydroxycobalamin. My experience has been very similar to yours. I don't really think about it that much because the patient comes in and they've already got it hung. It's already going in if they've come by FDNY. So that makes it a lot easier for us. And I think it's good to have some of those things in mind of where I should be reaching for that. And you also mentioned carbon monoxide in there. I think that's the one that we maybe underestimate how important it is. Most of what we're going to be doing is giving high FiO2 to flush out that carbon monoxide, but there can be pretty significant morbidity if we're not focused on that carbon monoxide poisoning as well. So you gave a plug for it before. We want to get carbon monoxide levels on all of these patients who are coming in with significant smoke inhalation because we can't just focus on the burn. We got to think about the other things that might be causing problems for that patient as well. So think about the carboxyhemoglobin, think about cyanide as well. I don't think we should be necessarily liberal with hydroxycobalamin, but there are clearly certain indications where we should be reaching for it. And then there are the other indications like you draw blood and it's chocolatey, it's got that chocolate color to it. Sure, we're going to reach for hydroxycobalamin. If you're seeing some kind of a disparate reading between your oxygen saturations and the patient, that's going to be another indication. So we have those in the back of our head, but there are certain triggers that we should be reaching for this right away. Cardiac arrest is one of them. And then again, with that large burn in an enclosed area, we should be thinking about it as well.
That's correct. And I'm sorry. And again, in our area, the FDNY will often start it, but it's recommended to redose it, the cyano kit or carboxycobalamin, which is essentially vitamin B12. And the mechanism of action is that it directly binds cyanide. So it turns hydroxycobalamin into cyanocobalamin. So it's a direct binder of the cyanide. So it takes it out of solution. And with an inhalation injury for carbon monoxide, the main treatment is oxygen. And so what we do is if the patient's intubated, we start at 100% of oxygen, or if they're 100% face mask, we recheck the carbon monoxide or carboxyhemoglobin level in about an hour. And usually the half-life on 100% is about 40 minutes. And then after we see the carboxyhemoglobin less than 5, then we start to back off the oxygen.
Excellent. Now, we focused a lot on burns, and in the emergency department, we do think about flames, we think about hot water burns, hot oil burns, but there are other burns that you guys manage as well, and other patients you manage as well in the burn unit that we should also be considering getting our burn specialist on the phone or consulting those specialists.
That's correct. And the other two big ones are electrical injuries and chemical burns. The main thing with electrical injury is cardiac. As we all know, the heart is an electrical organ, and with an electrical injury, that electricity can be altered, and we can get arrhythmias. So the first thing is someone has an electrical injury, we want to think about cardiac. The second issue with electrical injury, once the cardiac is stabilized, is we want to make sure that we don't have a compartment syndrome. The electrons cause compartment syndromes when they stop moving, when the kinetic energy is changed to heat energy called the Joule effect. So again, initially, the electrons come through the epidermis, and our body acts as a sink, travel via nerves, so we can get nerve injuries or pain and tetany, what have you. But when the electrons hit the periosteum, they stop moving, and that heat energy starts from the resistance of the periosteum. And you can have very edematous compartments, and you need to have a fasciotomy at that point. So for electrical injuries with compartment syndrome, we're going to think about an emergency fasciotomy. And the third thing with electrical injuries, we can have renal failure. You have rhabdomyolysis and then renal involvement. So you want to give more fluids to flush the kidneys. You want to alkalinize the urine with sodium bicarbonate. And you want to also flush the urine with mannitol, flush the kidneys with mannitol. So those are the three things we want to look for with an electrical injury. With chemical burns, irrigation is the main treatment. How long should we irrigate? Hours. So we should irrigate at least 2 hours. And if the patient is still having symptoms, burning, what have you, then we should irrigate up to 6 hours sometimes. It can be very difficult, space in the emergency room, pediatric patients, ocular injuries, but we really need to think about just irrigating. The one big one, obviously, is the hydrofluoric acid, because the fluoride ions can chelate and take calcium and magnesium out of solution. It can cause hyperkalemia. You can get arrhythmias, pain, what have you. And the mainstay is calcium gluconate, either topical or even intraarterial.
Mike, I've definitely benefited from having such advanced burn care at my disposal right in the hospital, but we know that most emergency docs don't have that. They don't have burn units in their hospital, and they are having to ship their patients. They have to call a consultant for that reason. Let's talk about what our burn unit in Staten Island University Hospital offers to our community that maybe can't be provided at other hospitals that don't have that kind of specialty care.
We started the burn unit in 1998, Dr. Finkelstein and I, and over the 25 years that we've been here, we've grown in our sphere, and we receive patients literally all over the tri-state area, certainly burn patients, and we're starting something called teleburn, which is going to be throughout the Northwell system, where emergency doctors can literally not only just call us, but can have us speak with the patient, speak with the emergency room physician, and then we can decide along with the emergency room physician whether to transfer that patient to a burn center, either here at Staten Island or another burn center, or if the patient can be safely discharged with follow-up with us. But in addition to burns, we'll also admit Stephen Johnson's or TINs. These are drug reactions which progress to systemic involvement. So we'll receive those patients from literally all over the tri-state area. In addition to some very large injuries, we have a patient from Westchester who had necrotizing fasciitis involving much of the left side of the chest and abdomen. And the doctors, the emergency room doctors, and the surgeons at that hospital did a great job with the initial debridement. But then they were sent to us for the reconstruction, and the lady walked out. So it's very rewarding.
Excellent. So many services that we provide. I just want to do a little bit of a recap of all of the areas that we touched on because they're so important. We started by talking about fluid resuscitation, and we can estimate the size of the burn. And when we're talking about fluids, we're talking about the second and third degree burns. We can estimate using the rule of nines, apply the Parkland formula. And the key here is to start with a bolus, reassess the patient, look for good perfusion, look at that blood pressure, look at that urine output, and that's going to tell you whether you need more fluids or if you need to pull back a little bit. With airway management, obviously the patient's in respiratory distress, you're going to intubate them. If they have signs of upper airway compromise, intubate them early rather than waiting, because as they become more edematous, either with your resuscitation or just the progress of the disease, it's going to become more difficult to intubate those patients. And like Mike said, in general, if you're on the fence, you think you might need to intubate, but you're not sure, you probably should take the airway before it becomes more difficult. In terms of the escharotomy, the key thing for us to be looking for is the disappearance of a pulse that was initially there. Typically, this is going to be with circumferential third degree burns. Find that pulse when the patient comes in. If the pulse disappears, you're going to need to do that escharotomy. If the pulse is still gone after the escharotomy, consider the fact that you might need to do a fasciotomy for that patient. We talked a little bit about some tox stuff, always makes the EM folks happy. Always think about carbon monoxide in these patients. You're going to fix that by giving lots and lots of oxygen, but also consider cyanide. You're going to treat that with hydroxycobalamin. Fortunately, in the New York area, a lot of these patients who are at higher risk for cyanide toxicity are getting the hydroxycobalamin in the field. And then I think finally, it's important for us to remember that our burn specialists don't just deal with heat burns. They also deal with electrical burns. They also deal with chemical burns. And as you mentioned at the end there, things like necrotizing fasciitis, things like SJS and TEN, that all falls within the purview of a good burn specialist and a good burn unit, which is what we have and a service that we can really offer to our community. Mike, thanks so much for coming on and talking about all this stuff with us. I can't wait to have you back on when we have more controversies, more questions about burn care.
Thank you for having me.